Good evening, everybody, and welcome to the Eternity Playhouse, a beautiful theatre right in the heart of inner city Sydney, and a very fitting space for us all to come together and look to the future, to what a future HIV response looks like in New South Wales as we move out of the last phase of the current HIV strategy and cast our minds to what a future might look like. On behalf of everyone at ACON, it's my absolute pleasure to welcome you all here this evening. One of the most rewarding parts of my job at ACON, and there are many, is that we do have the opportunity to host events like this, but bring people together, not only people from our communities, but those sector partners that ACON works with who have been and remain critical to the HIV response here in New South Wales. Welcome. It's a very deeply personal and privileged position I hold to be able to welcome you all here this evening. Before we commence this evening's forum, I'd like to take this opportunity to invite Ray Davison to the stage to offer a welcome to country on behalf of the Metropolitan Local Aboriginal Land Council. So welcome, Uncle Ray.
Thank you so much. Good evening, everyone. My name's, as was said, Uncle Ray Davison. I'm here this evening on behalf of the Metropolitan Local Aboriginal Lands Council. The Lands Council and its members being the custodians to the clan groups of the Eora Nation give me permission this evening to come along and welcome you all to country. I'm also here this evening on behalf of the traditional people, my people, the Gadigal people, once again, to invite each and every one of you to country. So you all know that Welcome to Country goes back many, many thousands of years. We've always had Welcome to Country when we have big celebrations, the big corroborees, and we celebrate by song and dance. It's done today as I'm doing it orally. It's no less significant, it holds the same importance. So this evening is a gathering, this evening is a corroboree, so we're here continuing on that tradition that's been going on for thousands of years, because Welcome to Country doesn't see Aboriginal or non-Aboriginal, it just sees us as Australians. So regardless of whether we've been here for 10,000 years, 1 year, or a new child born today, if you're born on country, then you're part of country. I love reminding us each time I give Welcome to Country that we all have one mother. It's Mother Earth. Mother Earth knows each and every one of us. She loves each and every one of us equally. And no matter who we are, once again, or where we come from, we're all part of the same and we all belong. So regardless of the length of time that we're here. So just in keeping with Aboriginal custom and protocol, I'd like to pay respects to elders and descendants both past and present of my people, the people of the Eora, and thank them for the caring of the waterways and the land for the thousands of years of which we all benefit from today. And extend that welcome and gratitude to each and every one of you, and pay respects to your elders and descendants both past and present as well, for without those people, none of us would be here today. So it's wonderful to be here tonight, so thank you all, and I hope it's really, really, really special tonight. Thank you.
Thank you so much, Uncle Ray, for that very gracious welcome to country. At ACON, we recognise and stand in solidarity with our Aboriginal brothers and sisters. And with our new Reconciliation Action Plan, we're on an organisational journey to do more to acknowledge and support Aboriginal communities across New South Wales. And with that, I too would like to pay my respects to elders past, present and future. And thanks again, Uncle Ray. I'd like to thank everyone once again for coming along this evening to explore this really important paper and topic that we're looking at this evening, Imagining HIV in 2030. ACON will be turning 35 in 2020, and as we reflect on that milestone, I'm reminded of the ways that our community came together in the early 1980s. In the face of a now and a very much not well understood virus that was devastating the lives of gay men and their loved ones all across the world, it was a community here in New South Wales that really came together and arguably has led the Australian response since that point in time. Our communities then, as they are now, have been central to the response. Gay men talked, gay men took action, and we mobilised, as did other affected communities, particularly sex workers and people who inject drugs. The medical community worked hard to understand and treat the virus, and the bravery of those early clinicians remains respected and indeed honoured today. The scientific community quickly came together to conduct research, to understand transmission, and to search for life-saving treatments. The policymakers drew together their best advice, best evidence, and took brave and pragmatic steps to put in place programs and services, as well as policies that would help and not hinder what the response should be to fight HIV and AIDS. Then, as now, we continue to come together as community, researchers, clinicians and policymakers, and I'm reminded of the centrality of that partnership and the unwavering commitment that is needed to make progress. I'm also reminded that in the early 80s and the 90s in particular, how inconceivable it would be to have thought that in 2019 we would still be discussing how to end new HIV transmissions. So while we've got a task ahead, we have made incredible progress from then until now. And while we have the opportunity tonight to reflect on the massive declines in new transmission and to reflect on the health issues, particularly of HIV-positive communities, being largely good, and now we're looking at the complexities of ageing within the positive population, how much indeed we have to be grateful for and also rejoice. The paper we're launching this evening, Imagining HIV 20 in 2030, has really been a labour of love for many in ACON, and I'd particularly like to thank our policy, strategy and research team, and especially Dr. Ben Bavington from the Kirby Institute. I think ACON's pretty well known in New South Wales for our work in delivering health promotion campaigns and messages, and I'm sure that many of you would have seen that work. Certainly since 2013, our Ending HIV campaign executions have been on your Facebook feeds, your mobile apps, in community venues, on bus shelters, train stations, and even covering the obelisk in Hyde Park. It's pretty much been everywhere. However, the work that the policy team undertakes in the policy space is far less visible, but has in many ways been equally as important to ensuring that our communities are supported to live their healthiest lives and that we have a voice at the policy table in formulating HIV responses here in New South Wales. I think the paper that we're presenting this evening is a rare opportunity where we take the time to look forward and to contemplate the different paths that lie ahead. It's also timely, given that ACON has just released our new strategic plan. And as we develop responses for our health communities over the next 4 years, we've also challenged ourselves to think about the longer term responses to HIV that are needed and the broader social, political and biomedical changes that will affect and shape the environment in which we're going to need to operate. I guess inherent in the difficulty in undertaking a task like projection thinking or forward thinking and imagining the future, it really comes from the need to speculate and extrapolate on current data and trends so far in advance in such an uncertain landscape. Certainly, I think we can characterise the response to New South Wales, particularly since HIV, since 2012 as being internationally remarkable. New South Wales has really stood tall as a jurisdiction to take on new opportunities and to ratchet up the response. We've had bold policy targets, we've had more accountability from LHDs, we've had testing at historic highs, we've had new technology like PrEP rolled out at scale and at speed, and we've sustained high levels of community health literacy. However, with all that's been achieved, there is a core reality of where we're at now and where we're at with this paper. And that unless we continue to move forward with expediency, then complacency runs the risk of halting our progress. And we need to start thinking about our future and the service settings and making sure the service settings and the policy environments are aligned. There is indeed much more work to be done. There's more work to be done for people living with HIV, and certainly there's more work to be done for people at risk, particularly those who are part of our communities at the centre of an increasingly divergent epidemic, which you'll hear more from Ben about. And certainly there is more work to be done in ensuring that access to treatment and prevention is universal. Within that, and building on three decades of learning, we recognise how critical it is for the meaningful engagement of people living with HIV to continue into the future. As Steve Burberling has mentioned in the report, Steve is an ACON board member, the leadership and contribution of people living with HIV in Australia, in the HIV Australian response, is public health at its very best. The Imagining HIV 2030 paper is broad in its scope, and it explores the social, the medical, the scientific and the public health approaches that have the potential to influence and affect our communities in truly significant ways. With a move towards the study of HIV vaccine trials in humans, the search for a cure and a vaccine is undoubtedly the next most critical breakthrough. However, we know that such a development and at scale is not within sight. Continued investment and dedication to our core work is essential. Despite record low levels of HIV notification rates in New South Wales, now is not the time to take our eyes off the prize and to lose our focus. We must continue to invest, we must continue to work, and we must continue to act as policymakers, researchers, clinicians, and community members to ensure the best outcomes for everybody in our communities. This paper really speaks the truth. There is no certain future for HIV in New South Wales. So the actions that we take now and what we do in responding to HIV will dictate what occurs into the future. So tonight, what we're really looking to do is stimulate thought, discussion, and hopefully continued action. And with us on that journey, we're very fortunate this evening to hear from fantastic minds on this subject. Our keynote speaker is Dr. Ben Bavinton, who is a research fellow at the Kirby Institute at the University of New South Wales. Ben has worked for many years researching the behavioural and epidemiological aspects of HIV prevention amongst gay and bisexual men in Australia and indeed the Asia Pacific region. Ben was a project lead for the Opposites Attract research study, which looked at treatment as prevention strategies in serodiscordant couples, and he is also an ACON board member. He was integral to the development of this paper until tonight. Ben's going to talk us through some of the key data and set the scenes for the panel discussion. Following Ben, we are delighted to welcome Benjamin Law to facilitate our panel. As I'm sure you all know, Ben is a prolific and considered author with credits including The Family Law and Gasia, Adventures in the Queer East. Ben regularly contributes to The Guardian and Quarterly Essay and is the editor of the recently released Growing Up Queer in Australia. It's an honour to have Ben with us this evening to facilitate our discussion. Ben will introduce the panel, but I'd personally like to thank Dr. Kerry Chant, Dr. Horace Wong, Professor Tony Kelleher, and Lance Feeney for being with us this evening. After the panel concludes this evening, I'd also like to invite you all to stay for some refreshments, and we hope that this evening's format will give you lots to talk about. We look forward to a great night, and we also look forward to working with you over the years to come and to continue our journey, if you like, to revolutionise contemporary HIV response. So, on that, I will now hand over to Ben. Thank you.
Thanks very much, Nick. So I've been given the task here of, sorry, where are my slides? Okay, being given the task here of really summarising the research that is encapsulated in this report. There's a huge amount of research in this report, so I can't cover a lot of what's actually in there. I'm really only going to be focusing on two main topics in this sort of 15 to 20 minutes, really looking at some trends in the epidemiology and some other sources of data, just sort of think about what might happen in the next sort of 11 years. And then also talk about some of the upcoming technologies that are really coming down the pipeline that are really potentially going to shake up our HIV prevention and treatment responses. So first I'll start with the recent trends. So this graph here is probably familiar to a lot of people, just showing the number of diagnoses that are new diagnoses that are diagnosed within the state of New South Wales. So you can see there the good news story that's been mentioned already, that over the last few years we've seen these sustained declines in the number of infections. But of course a simple graph like this doesn't give you much of the story, so I've got several more graphs to drive down a little bit more into it. The first is to look at the division between men who have sex with men, or male-to-male contacts, exposures for HIV diagnoses, and then the heterosexuals in the gold along the bottom. You probably can't actually see that very well. Sorry about that, but there's a line along the bottom, around sort of 50 infections a year, which is in the heterosexuals. So the first thing you'll notice here, of course, is that sustained decline that we're seeing is really being driven by the male-to-male sex exposures. And the heterosexuals exposures have really stayed the same for really the last 10 years. So a bit more work is needed there. For the rest of this presentation, I'm really just going to be focusing on the men who have sex with men. As you can see from this, they do make up the bulk of the infections in our community. So for the rest of it, it's really drilling down into that red line you can see there on the graph. This next one is really showing an important issue that a lot of us are grappling with across the entire HIV sector at the moment, all sections of the sector. And this is this question of country of birth. So what this slide is showing in the black is the men who are being diagnosed, newly diagnosed, who've been born in Australia. And in the red, the men who are diagnosed in New South Wales who were born overseas. And what you can see very clearly here is that dramatic decline in infections that we've been seeing over the last few years is really only happening in the Australian-born men who have sex with men and not in the overseas-born. You can see that it's either flat or potentially even slightly going up. And so now, I can hardly see this, but so now it's the men born overseas are making up the majority of infections, not just in number, but also in proportion. So it's now 57% in 2018 were overseas born, and the other 43 are Australian born. The overseas born are really being driven by men, mostly men from Asia, but you can see there that there has been a bit of an uptick in those born in other countries, which has mostly been driven by people from Latin America in this state. So driving a bit more down into the line of the overseas born, an important question is where people believe they've actually acquired their HIV from, because this really determines what kind of responses we can put into the community and the types of things we need to be doing. So you can see that on the left, you've got those who are born in Australia, and on the right, it's those who are born overseas. And in the red, you've got people who believe they acquired their infection overseas, and in the black, the people who acquired their infection in Australia. So you can see there's a stark difference between those born in Australia and those born overseas. The Australian-born, over 3/4 of them believe that they were infected in Australia, whereas it's only about half of the overseas-born. And the fact that it's only half is really important because it means that there's two very, very different things going on in that overseas-born community or those overseas-born men. You've got some men who are arriving in Australia HIV-free and then engaging in the sexual cultures here and picking up HIV. And then you've got another group who are arriving, migrating or coming to study, who bring the HIV infection with them. So the kinds of responses and the kinds of things we need to be doing are quite different for those two groups. The people who are bringing HIV with them really need to be encouraged to test. And as soon as they get tested, we need to try to get them onto treatment as fast as possible. And the people who are acquiring HIV here, we need to be thinking more about prevention strategies like condom use and PrEP. So another area, that's all I'm going to say about country of birth. So another area that I think is really taking up a lot of our time in our thinking is this question of location of residence. So what we've done here is we've divided every postcode in New South Wales into how gay the postcode is. So we basically find out where all the gay men live, and then we categorise them all and say a gay postcode is a postcode we're considering to be over 5% of the men who live in that postcode are gay. And so all of the gay postcodes are located in central Sydney. It's kind of out to Wallara, out to, I can't remember how far, maybe to Marrickville a little bit further, up to North Sydney and then down to the airport. That's kind of like the gay centre of Sydney. And then you've got the other Sydney suburbs and then the other New South Wales suburbs. So what we're also seeing in these trends here, you can see in the red line, which is the gay suburbs, how we're again seeing that decline that's been happening for quite a few years. Whereas in the black line, you can see that it's sort of crept up for a few years and then since the rollout of PrEP may be coming down a little bit. And then in the gold, again, I'm not sure how well you can see that, it's been creeping up slowly. But what this means on a proportional basis, which is the second graph on the other side, is that now the majority of the infections are now happening not in the gay epicenter of the epidemic or the community, but outside of that epicenter. So again, this means we sometimes need to think about how we do our prevention and treatment work differently. So to explore these trends a little bit more, I want to also talk a little bit about HIV testing, HIV treatment, and a little bit of data about HIV prevention. So the first thing to say is we've had great success in New South Wales in increasing the absolute number of tests, HIV tests that are performed in this state each year. You can see it's a year-on-year increase across over time. I'm not sure if that's going to level out at some point, but we hope it won't. And we hope that new strategies like home-based testing and the DBS, the dry blood spot testing, and other kinds of things will keep that ramping up. Other things in terms of HIV testing, about 9% of gay and bisexual men in our surveys say that they've never been tested. So while we're having this great number of tests year on year increase, there is still this very stubborn percentage that stayed the same for a lot of years now of people who say they've never been tested. And these are community attached men who are attending things like Fair Day and going to sexual health clinics and going to bars. So this is a bit of a concern that stayed so stubborn. On the other hand, frequency of HIV testing has been increasing. So what that's showing in the top, in the gold at the top, is 3 or more tests in a year. And you can see how the proportion who are reporting 3 or more tests in a year is really increasing quite rapidly over the years. But I'm not showing these data. Most of that increase is happening in PrEP users, and it's not happening outside of PrEP users. And the other thing to point out is about that black section along the bottom, that about 1/4 of these sexually active men are saying that they hadn't had a test in the previous year. So again, something we need to think about. In terms of HIV treatment overall and also time to initiation, so we're doing very well in the area of HIV treatment. For those who know about the 90-90-90 UN/AIDS targets, we smashed those targets in 2016 and are now very much working towards 95-95-95. So we've got about 95 of the diagnosed HIV positive people in New South Wales on antiretroviral treatments, or ART. And this is a bit of a busy graph, but what this is from the data reports produced by the New South Wales Ministry of Health. What this is showing in the green line, that we're now at a point where 83% of the newly diagnosed HIV positive people in the state of New South Wales are being treated within 6 weeks of their diagnosis. And you can see how massively that has increased from the green line there from, I think it's about 1/3 or a few years ago. And 95% start treatment within 6 months. So this graph really is a huge success story for our state, and hopefully we can get it even higher than 95% over the years to come. There are some inequities emerging here as well, though. The main one would be in the under 30s, those aged under 30, who are at a slightly lower level of treatment, and then even when they're on treatment, have a slightly lower level of undetectable viral load or viral suppression. So I think that's something we need to be focusing on as well. So in terms of PrEP, as I'm sure most people in this audience knows, that EPIC New South Wales was our large-scale PrEP implementation trial that started in 2016. The trial ended up enrolling about 9,500 high-risk gay and bisexual men in New South Wales onto PrEP all over the state. Since PrEP was listed on the PBS on the 1st of April 2018, it's a bit harder to track how many people are actually on PrEP. We're struggling a lot with this at the Kirby Institute. But we do think from various data sources, such as the PBS data source and also the community surveys that we run, that it seems like people are continuing to initiate PrEP. Maybe not at the same rate, we're not really sure, but there does seem to be people continuing to initiate. Where we're at right now in terms of our community surveys, so this is gay and bisexual men, not all men who have sex with men in the state. We think there's about 44, maybe a little bit more than 44% of the people who are eligible for PrEP who are taking it. But as mentioned, well, sorry, it wasn't mentioned here, it was at another meeting I was at today. What the target that we're actually aiming for nationally is 75% of the eligible people to be on PrEP. So we're only at 45, we do actually have a long way to go, and there are some inequities emerging here as well. We need to focus again more on that younger age group. We need to focus on people who don't live in the gay suburbs, and then what's the third one there? And then also those people who are not eligible for Medicare, which is obviously mostly overseas-born people. In terms of condom use, this tends to get a lot of press when we show figures like this. Condom use, condomless sex has decreased or increased in our community. You can see it was very flat at about 35% for quite a few years. PrEP came along and condomless sex did increase. But this is a completely expected and rational response to the introduction of PrEP and U=U. It's not unexpected. And it's really important to note that the proportion of gay men who are protected by any effective strategy, so undetectable viral load, PrEP, condoms, not having sex at all, has now grown over time. And now it's at 3/4 of the men who are having casual sex are protected by some form of strategy, effective strategy. So that's really important. So even though condomless sex has increased, so has the level of protection. And also increasing use of PrEP and use of U equals U in sexual context means that when a negative or untested person in the community, gay man in the community, does have condomless sex with a casual partner, the chances that he's having a condomless sex with someone who's actually on PrEP or undetectable is much higher than it was, say, 5 years ago. So this is what gets referred to sometimes as herd protection, or in the vaccine space, it's herd immunity, which is this idea that if you have enough people on an effective method, then the ones that aren't on that method may still be protected by the people who are. Of course, this relies on a concentration of PrEP users, and this might explain why in sometimes outside of those gay areas of Sydney, we're seeing those increasing infections. So the last thing of this section will be trying to make sense of these trends for how we project this forward to 2030. So it is difficult, as Nick said, to project 11 years into the future and think what's going to happen. I think HIV diagnoses are likely to continue to move away from that very gay, connected, community-attached epicenter in various different ways. And each new HIV infection is likely over time to become harder to prevent and potentially also to diagnose. So I think what's going to happen is that the trends that I've talked about tonight, such as country of birth, age and location, won't necessarily be the same trends that we're seeing in 11 years' time. But it is likely that HIV diagnoses will occur more in men who have sex with men who are less connected to the gay community, less connected to health services, experiencing more challenging life circumstances, including drug use, and who may be more marginalised from mainstream Australian society. So how that actually looks in 11 years may be different, but this is likely to be the trajectory. And how we respond, of course, is going to have a big impact on that. So already in the last couple of years, as soon as we noticed this country of birth issue, organisations like ACON, the Kirby Institute, other places started to respond. And we started to do new programming and services to really try to meet that need. So I think this is a very dynamic situation. Every time we see something in the data, people around the sector will actually start to respond to it. So we'll see what happens in the next 11 years. The next section that I just want to talk about is the upcoming developments in HIV treatment and prevention. I'm not going to talk about vaccine and cure. I'll leave that to Professor Tony Kelleher if the panel wants to talk about that. It's not my area. But I just wanted to talk about the upcoming developments really in prevention and treatment. I want to remind everyone that in 1960, there were really only 2 options to prevent pregnancy, and now there's this huge plethora of options for contraception. And the same thing is really happening in PrEP, or going to happen in PrEP and in HIV treatment. So in terms of HIV treatment and PrEP, I've put these together, but I'm going to sort of talk about some of them separately. So there will be new drugs and there will be new dosing regimens. We already know the on-demand PrEP or event-based dosing, or the 2-1-1, whatever name you want to use, which is the idea of taking 2 pills right before you have, or 2 hours before you have sex, and then 1 pill per day for 2 days after. We know that this is effective. This has been proven. Half of the people in France and in the Netherlands are using this strategy, and the HIV incidence is still very low. We know this is effective. It hasn't been talked about very much in the New South Wales context. I think that will change in the next year when the new guidelines around PrEP get released, and I think we're going to see a lot more activity in that area. In the area of HIV treatment, there are now going to be 2 drug formulations rather than 3 drug. This is great for HIV positive people. It means there's less of a drug burden, potentially less longer term toxicities, and potentially a higher safety profile for those drugs. We may move to a place where we have once a week oral pills or capsules that just slowly release the drug over time. And we're going to have better drugs with better safety profiles and less side effects, fewer side effects. There's also going to be long-acting formulations, and this is probably what you would have seen in some of the media reports coming out of the recent HIV conference in Mexico City. So one of the first ones is, that's really probably the most progressed is long-acting injectable treatment and PrEP. So this is going to apply both for treatment to HIV-positive people and for PrEP in HIV-negative people. Most of the regimens so far are people coming in for 2 relatively large injections about every 2 months. That may be improved over time, so we may be able to increase the time between those injections. In the prevention area, I've just put 2 logos up there of 2 very large studies of sort of over about 5,000 people each, which are exploring the prevention side of this drug called cabotegravir. And those studies should both be reporting in about 2021-22. So at that time, if we find that this long-acting injectable PrEP is just as effective as daily oral PrEP and on-demand PrEP, then that means we need to act pretty quickly. We need to think about how we're going to bring that into the New South Wales context for those people who need it. The next area is injectable and implantable implants, or insertable implants. So there's really two areas of research that are happening here. Again, this applies to both PrEP and to treatment. The first one on the left there is similar to the contraceptive rod that is currently used now, where it just gets inserted under the skin and then slowly releases the drug, potentially up to about a year. They've only proved it for about 3 months so far, but we're still waiting on the studies to see how long the drug will be released for. And then the one on the right is a different type of implant where it actually gets injected as a liquid, but then it solidifies. There's a polymer in it that solidifies inside the body and then slowly breaks down over time, which thereby releases the drug. So these are both in development right now. There's no large-scale efficacy trials or trials that are trying to prove whether these prevent HIV or whether they work as treatment yet, but that will be happening soon. Another exciting area is the area of patches. So these are these microneedle patches. So that image on the right are these really tiny little needles, like invisible to the eye. And the patch is actually quite small. You can see that was one of the investigators that gave that presentation in Mexico City, showing how it works. So again, this can be used to slowly release both drugs for both PrEP and treatment over time. Again, that's a little bit further away, not in large-scale trials yet. There are a few other things going on, perhaps a little bit less relevant to our epidemic here. There is microbicide research happening. So this is basically topical PrEP, the idea that you apply PrEP just to the area of the body that you actually need it. So that might be in the rectum or it might be in the vagina. There's a few different products that are in development at various stages of development. There's gels, there's sort of like douches. So if people are going to be douching anyway, they can just use this microbicide that will then hopefully seep into their cells and protect them. There's also vaginal rings. This is unlikely to be something that we would probably see a lot of here in our context in New South Wales. Just important to mention that this is a huge thing for sub-Saharan Africa. This is really just for PrEP. There is a trial that has just reported, and there is some hope that they should be able to get a ring to be up to about 50 to 70% effectiveness in the future, and hopefully that can get better over time. And then finally, there's this area that's broadly neutralizing antibodies. Again, I'll leave Tony to explain what that actually is. My understanding is that this is where you actually find these antibodies that have been created inside the bodies of HIV positive people that then broadly defeat the virus in that body. So then they take that, they amplify it, make a lot of it, and then they can infuse that into people's bodies, into negative people's bodies and positive people. So we may get to a point where people don't actually need to be taking antiretrovirals to be able to either suppress their virus or to prevent HIV. There's 2 very large clinical trials underway right now called the AMP studies. Again, they're very huge. They've got several thousand participants in each. One's in men who have sex with men and one is in women in sub-Saharan Africa. And they should be reporting again in about 2021-22. So that's going to be quite an exciting time for this type of research. So just to conclude, so I'd say clearly the HIV epidemic in New South Wales and in Australia is changing and our responses need to keep up. It's important to retain those successes that we've had in those gay community connected, Australian-born and other kinds of people who really have been typically at the epicentre of our epidemic in Australia and in New South Wales, while at the same time increasing a whole range of new pieces of work that we need to do to engage communities that have been less connected or groups of men that have been less connected. More work, I didn't talk about this in this presentation, but more work is clearly needed on addressing HIV stigma, continuing to educate the community, not just the gay community, the broader community about the amazing findings of U equals U, and also just trying to fight homophobia, biphobia, and transphobia in our communities too. And so many new treatment and prevention options are going to be coming out over the next 10 to 15 years. And so our challenge will be to make sure that we get those products to the people who need them in our context in New South Wales, once they're proven effective. And once we have access to those, really making sure that that's an equitable distribution to make sure that people aren't left behind. Because some of those products are going to be most useful for some of those people who are struggling the most right now with taking, for example, a daily pill or a set of daily pills. So I will leave it there. Thank you very much.
Hello, everyone. Have we got some microphones coming down? Fantastic. Thank you so much for that, Ben. I am also Ben. I'm I'm very stoked to be here with you on Gadigal land. And I think, especially now in the year of Indigenous languages internationally, it's contingent on all people, but especially non-Indigenous Australians, to not just know which country we're on, but also a bit of language as well. So in Darug, the language of the Sydney Basin, g'day is Worimi. So Worimi, everyone. Worimi, yeah. Okay, fantastic. We got that. This discussion makes me think that New South Wales and Australia has always been a role model for the rest of the world in its innovative, effective, proven results in approaches to addressing HIV. So much so that, of course, if you travel around the world and talk to people working in this sector, the Australian model is often referred to as the benchmark of how to address HIV. So this conversation, I think, is a great opportunity to look at where we should and want to be in 2030, only 11 years away. So now to reflect, celebrate, but importantly, cast our eyes forward to the next 10 years and dig into the nuances of this report, could I invite some of our guests up onto the stage? So our first guest is public policy physician, currently the Deputy Secretary, Population and Public Health and Chief Health Officer. She has extensive public health experience in New South Wales, having held a range of senior positions in public health. Please welcome Dr. Kerry Chant, everyone. Our next guest is a clinician scientist and professor and program head at Immunovirology Pathogenesis Program at the Kirby Institute. Please welcome Professor Tony Kelleher. Our next guest is a registered nurse, social public health researcher at the University of New South Wales, doing much work looking at ethnic Chinese gay men and HIV. Dr. Horace Wong, everyone. Our next guest is an advocate for people living with HIV, has worked with ACON Positive Life over the last 20 years. Lance Feeney, everyone. So we're just blitzing through this, as you can tell from the tone of my voice. We're running out of time. And I'm also going to welcome back the head of ACON, CEO of ACON, Nick Parkle, everyone. I'm going to go through a bit of a blitz with all of you, but I want to start with you, Professor Tony, if I can, because one of the things that we heard before is that in report there's a discussion of this kind of long dream that we've had in the HIV sector, which is about vaccines and cures. That is brought up in the report. Where are we at and where's the conversation?
Yeah. Both vaccine and cure, I think, are two of the grand biomedical challenges that remain in this condition. And I think if we've got either of those by 2030, we'll be doing very, very well, unfortunately. So in the cure space, a lot of what people thought would work by turning on the virus and the cells left in the reservoir dying because you've turned on the virus has not borne a great deal of fruit. So there's been a range of phase 1 and phase 2 trials that have shown very limited ability of these drugs to turn on the virus and very little cell death of the cells producing that virus. So no change in the reservoir. And the other problem with that approach is that it's relatively non-specific and turns on other genes within the body as well as HIV. So I think there's a lot more work that needs to be done in that space to get more precise interventions. The other way to do this is to either cut the virus up or delete it from the cells, or to silence the virus within the cells or maintain its latent form, which it sits in the reservoir when people are on antiretroviral therapy. And the way to do that is really gene therapy. And although there are some very promising molecules to deliver the gene therapy, and they work very well in a test tube, to deliver the gene therapy to the latent reservoir precisely is a very big challenge. And so there's a lot of work going on with nanoparticles and various cellular therapies to do that. I mean, it's clearly possible to do that with both the Berlin patient and now the London patient, but they're the exception rather than the rule.
And in the meantime, Tony, we saw these kind of myriad possibilities coming up in terms of the evolution of PrEP and treatment. Do you feel optimistic and positively towards those developments?
So I think that those developments will allow us other options for treatment and for PrEP. And I think it will provide choice to people about how they either take their therapy or take their PrEP, which I think is advantageous, because particularly with either of these interventions in terms of keeping people well or preventing the disease, the problem without a vaccine is that we're really dependent on people being compliant and knowing about the availability of these things and finding these interventions acceptable. So if we have a range of those things that are easy for people to take and are more acceptable across broad communities, so having a long-acting implantable as either therapy or PrEP means that you don't have to have tablets at home, and you're not risking declaring your status to someone that you don't want to know. And so I think those things are very promising in terms of ways forward in providing choice and perhaps penetrance of some of these more difficult to get at populations, as that Ben highlighted.
And just before we pass it on to Dr. Kerry Chan, let's talk specifically about policy and research. What are the biggest gains that we've made most recently, and what are the biggest gains that we need to make in the next decade?
So I think, you referred to the Australian model. I think, the rate at which the world in general, but particularly Australia, responded to the results of the treatment as prevention trials and then START. So the treatment of prevention trials showed that treating the population was advantageous for the population, but START showed that early treatment was advantageous for the individual. So those things came along very close together. But unlike in a lot of other diseases, people got that immediately. The communities have been involved with the design of those trials. They understood the implication of those trials. We managed to engage with policymakers and then roll out those policies and implement them very, very rapidly. And you could see the figures that Ben showed that, since 2015, when START was published, within a couple of months of actually the result being known, we had a published paper and we were already implementing policy. So I think those sorts of nimble, rapid responses are just extraordinary and a real example to other areas of health where that implementation may take many, many years to convert.
Thank you so much, Tony. I'll pass the conversation on to you now, Kerry. Look, over the past 7 years, what would you say have been some of the most absolutely critical components of the relative success of New South Wales HIV policy and programs?
I suppose I just also want to start by acknowledging the traditional custodians of land, which we need, and pay my respects to elders past and present, and also just acknowledge and reassure you that New South Wales Health remains absolutely, totally committed to achieving the targets, and we will be in for the long game, of which it will be. I think one of the key things for me has been working with partners, and I think we've always worked with partners, but I think to some extent we really stood it up in 2012. It was at a new level. We engaged respectfully, but brought different views and prosecuted arguments and prosecuted ideas in a very real way, and I think that's a tribute. For me, the use of data, and anyone who knows me knows I'm passionate about the power of data, and I think that taking those steps very, very early to establish and grow the data reports, and for me, having engagement around those data reports in terms of what lessons it learned and then acting on it in that policy and program cycle was so incredibly important. I think flexibility and innovation. We embraced new evidence, how to use point of care. We learned, we tried something, we learned. We had a debate about in which populations would it be useful. We've innovated for dried blood spots testing. I think we've stood up to the challenges, the emerging challenges around the called population, the non-gay identifying, the issues you raise about suburbs that are not highly represented by gay members, and the challenges of engaging that. And I think for me, I'm really eager to see some of the outcomes of some really novel campaigns such as the Discreet Life campaign and some really innovative ways in which we engaged with that community, which is sort of even outside our traditional research framework in terms of market research companies as opposed to traditional research. It really challenges us to think outside the square, but to do that in partnership and to make sure we act and are committed to acting on any of the learnings. Obviously, I'm really proud of EPIC and dry blood spot. I'm really proud that we've been able to manage better initiation on treatment and the engagement, and I'd like to acknowledge the community's advocacy in that regard.
Kerry, one of the words you brought up is flexibility and also the challenges ahead. One of the core things that this report focuses on is the idea of divergence and the fact that different communities will have HIV manifest or they have to address HIV in different ways. That's something we'll talk about later with Horace. So how do you remain agile in approaching different communities when addressing HIV?
We've just looked at I've had the preliminary look at the new data report for the last period, and I know the data committee's meeting on Thursday to consider that, and some of you have seen that data. And I think it reinforces the presentation today. So for me, we are going to have to focus very clearly on what strategies we do for people that may be coming to Australia with HIV and how we can rapidly link them to care and how can we engage with them actively at that point. So engage them with testing, engage them with care, and understand the barriers that may make them unable, unwilling in some cases, or in some cases very fearful of engaging in care. So I think that's an area that's really key. We've then got to understand the populations that are not embracing the prevention, and those that are not embracing treatment, because as you've said, treatment is also got demonstrated individual benefits. And so we've got, whilst it's always an option for people to engage in treatment or care, I think we just do need to make it easier and understand why people are not choosing to take on treatment. So for me, it's about identifying those and stratifying those groups and then working with our partners, which is very much community, clinicians, and also I would challenge us to work with a broader range of clinicians. So we're going to have to engage our drug and alcohol clinicians, our mental health clinicians. We've seen the success of engaging GPs that are not our S100 prescribers. So we are diagnosing more people with HIV from our non-GP S100s. And so again, we've got to challenge ourselves not to just keep talking to the group that are the engaged, but look outside that to where we might have opportunities of leveraging other disciplines that may be encountering the same population group. And I think another challenge for us is to make sure that we don't, in engaging with those individuals, think about it from their perspective. So if their priorities are drug and alcohol, then we've got to offer those services seamlessly at a site for them. And so I think what in the past, our hepatitis C responses learnt very much from our HIV, but I think we can actually now inform some of our future HIV response with some of the learnings from our hepatitis C of what's worked and what hasn't.
Just finally, Kerry, you talk about community engagement and making sure that those other stakeholders and partners are engaged, and we'll hear from one of them very, very soon. But what does that look like? Like what are we looking for when it comes to meaningful engagement with those partners and stakeholders?
Well, I think our responses typified that. I mean, there's no discussion that we have around data. What should we do that doesn't occur without community? And the community groups tell us the reality. You know, they also can bring informal intelligence. They'll be able to rapidly respond. So for me, the community groups, and that spans, POS Life, ACON, but newer. And I wonder whether it's also other groups that we need to bring in around the table. Are really key, and I know we've been engaging more, understanding how do we engage with some newly overseas arrivals, our people that are coming here for education. And, if they don't actually connect with community, can we understand what are their other social networks and how we need to engage with them. So there's much to be done and much learning to be had.
Thank you so much, Kerry. That's a very good segue to you, Lance, when it comes to talking about community engagement and your work with Positive Life New South Wales. Where are we at in terms of meaningful engagement with groups like yours, and where do you want to see that progress in the next 10 years?
So I think the meaningful engagement has always been part of our traditional response in Australia. I mean, ever since those group of men got up in Denver in 1984 and said, look, we're not victims. We want a seat at the table, and we want to be actually part of every discussion that goes on, whether it be research, in program development. It doesn't matter where it is, we want to be part of that. So for organisations like Positive Life and ACON and the other community organisations in New South Wales and around the country, it's a matter of maintaining a very realistic dialogue between the community, and part of that is around education, but part of that is also around them feeding back to us a whole range of emerging issues and what HIV, the context of HIV in their lives. So we can then, I guess, look at data, which Kerry has spoken about, which is probably the most important thing of all, and give that data context and allow those programs to actually be developed and formulated in ways which are actually effective and they're meaningful. They actually resonate with the people who they're designed for, and they feel included, so that they accept those programs as something which is going to be benefiting them.
So much of, I guess, the safety of the HIV positive community really depends on the absence of stigma out there in the community. And it just makes me think that in the last 7 years, we've had this pretty big breakthrough when it comes to undetectable viral load, U equals U. Have you seen that knowledge out there in the community manifest as a lessening of stigma out there?
Absolutely. I think that the whole idea of treatment is prevention, and U equals U is just one part of that. But what that's actually doing is enabling people to understand that at the bottom line, treatment will actually prevent transmission. And I think U equals U is a very, very useful tool, particularly in the wider community, to allow them to understand a very simple idea. To actually educate the community that if you do have HIV, that you are taking effective treatment, that the chances of you passing on the virus are negligible. When it comes to actual positive people, I think we need a more nuanced approach, because we have heard from some clinicians that because of the different assays around testing viral load, that some people will come back with a reading which is under 200, but over sort of perhaps the assay that they were using. So there's a level of confusion. I think POS people are really pretty smart when it comes to this sort of thing, and I think we can talk to them about where their viral load is. We can talk about a spectrum of risk, going from zero viral load or, the most advanced tests right through to up over 200. And I think if we do that, POS people will have a much better understanding of where they sit on their potentiality for transmitting.
One of the important things about teasing out nuance is looking at the communities within communities as well. And what we're seeing with surviving, thriving people who live with HIV is that there's a population that's getting older as well, and senior people living with HIV. What are the issues surrounding seniors with HIV, and what could we be doing better, especially in the next decade?
Well, nobody wants to get old, but it's just a bloody reality. Anyway, in terms of the numbers, we've got a pretty substantial issue ahead of us. So I've just had some data back from our friends at the Kirby who have been doing some modelling, and in 2020 we've got 26% of people over 55 and about 12.5% over 65. By 2025, and that's not very far away, we're going to have 38% over 55 and 20% over 65. So 1 in 5 positive people in New South Wales is going to be over the age of 65. And there's a whole range of issues that underlie their risk factor for a whole range of health issues. So you mix in comorbidity, you mix in mental health risk factors, you mix in HIV-associated neurological impairment and dementia, you mix in frailty and things like functional impairment. You know, we know from research that's been done in the CURBID just recently that 13% of people over the age of 55 MSM have severe functional limitation and 26% have moderate to severe. And that's going to impact on their ability to be able to look after themselves as they get older, to get to the doctor, to get their prescriptions, to take their medications. All these things are going to actually require support. Then you add stigma and discrimination and polypharmacy and all these other things. So it's quite a complex piece of thing that we're facing.
So this is a demographic of the community that warrants critical attention in its own way. What are the other kinds of communities within the positive community that also warrant critical attention in other ways?
Well, as Kerry mentioned, in people who live in regional rural areas, I mean, for instance, in New South Wales, there's no private S100 prescriber west of Bathurst. So there's people who come from culturally and linguistically diverse backgrounds. There's gay men who live in isolation in rural and regional areas and even in areas of outer suburban Sydney. So these are communities, or these are individuals that we're going to have to work very, very hard with to educate them around treatment, but also testing, and to make sure that they have the best chance to maximise their health. Because it isn't an equal thing. You know, some people have very good access to services in the inner city. When you move out into regional New South Wales, it's not so good.
Thank you, Lance. We might pass the microphone over to Horace. I mean, you mentioned culturally and linguistically diverse communities just then, Lance, and that's a really good segue into the work that you've been doing, Horace. Your PhD was looking at the journeys of Chinese gay men, different HIV generations living in Sydney. What were the key findings that came up in your research?
So just a basic background of my study. So the study aims to understand the lives of ethnic Chinese gay men living in Sydney in relation to sexual health, in relation to sexuality, culture, and HIV. The participants were not only from China, although it's called ethnic Chinese gay men. Some of them were born in Australia, some of them were from Singapore, some of them were from the Philippines and Hong Kong. It was a qualitative study, which means I conducted a very long interview with each of the participants, and I asked open-ended questions about, we talk about sexuality, we talk about culture, we talk about HIV. And from what they told me, I tried to identify patterns and identify the factors that are affecting their lives. So there are quite a lot of interesting findings, but I think the most important argument of my study was that when we talk about HIV and Chinese or Asian gay men, we always have two assumptions. The first one is racism, that HIV, the Asian gay men always the victims of racism, and that's why they are vulnerable to HIV. The second assumption is that the culture, that Asian gay men always have certain kind of culture. They're conservative, they are reluctant to talk about sex, they put them higher risk of HIV. But in my study, I found that although these things might be true, but actually nowadays the Asian gay men, their lives is very changing. They are not living in like a cultural bubbles that separated from the rest of the community. They're actually changing, challenging all the stereotypes, and they are actually helping to define the sexual culture in Australia. And with factors such as globalization and migrations, a lot of Asian gay men actually have many resources transnationally, not only in Australia. They have linkage with other gay people around the world. So I think the message here is that my study is when we talk about HIV and preventions among Asian gay men, we have to think beyond culture and racism and think about more globalization and migration and how these factors are affecting their lives. Yeah.
And I guess what you're also reminding us is that no community, no culture is a monolith. It's not uniform. Right. And it makes me also think that because you're looking at generations, plural, of Chinese background gay men, what can you tell us about different attitudes that have come up or different practices because of these changing, emerging ways of prevention, you equals you, that changing knowledge bank?
Yeah. So in my study, I identified two different generations of gay men. The first generations, I call them age generations, that the gay men who witnessed what happened in the 1980s in Australia. So in 1980s, people HIV killing people, and then there was no effective drugs, and that's why the AIDS generation, we can call them like a survivor of the AIDS epidemic. And the other generations I identified was called post-AIDS generations. It's simply they didn't have the experience with that AIDS epidemic. Probably they were too young at that time, or probably they were not engaged in the gay community at that time, or probably they were just living in other countries and they haven't migrated to Australia at that time. So I think there were three major differences in their views. The first thing is about how they see HIV. Of course, age generation people, HIV is one of their major part of their lives. They witness how their friends died, they witness their loved ones died. So HIV has changed their life, changed their world, and have affected how they see themselves as a gay man or as a person. Whereas the post-AIDS generations, HIV is kind of a distance away. They talk to me about HIV. It's like that. A friend of my friends got HIV. I know someone got HIV. But at the same time, they're quite knowledgeable and they're aware of all these early testing, early treatment, frequent testing, all these things. Of course, whether they do it is another story, but they are aware of those things. The second difference, I think, is about the concept of gay community. The age generations, they have a very strong sense of gay community. They talk about the positive life, talk about the ACON. There was a very strong sense of community. Everyone was supportive of each other. There was a lot of love in that community. Whereas the post-age generations, it seems that the meaning of gay community has changed. It's more individualized. Everyone has their meaning of gay community. Some people talk about internet is my community. Some people talk about maybe the Asian gay man is my community. And this also affects to the third differences about how they see PrEP for age generations. It's quite interesting. The people I interview, they are quite skeptical about PrEP, and their concern is more about the gay community as a whole. At that time, I asked them, they were like, will PrEP introduce a new strain of drug-resistant HIV to the gay community that affects everyone?
That's interesting.
Yeah.
Where is that skepticism coming from?
Yeah, I think probably it's from part of them is from the gay community. What they witnessed, the experience of like people dying from a disease that with no treatment. So that's kind of skepticism, based on that. But the post-AIDS generation I interviewed, they are more open to this PrEP, taking medications to protect themselves. They also have concerns about PrEP, but the concerns more individualized, not like a strong sense of community. It's more like, what's the side effects? How do I get them? Is it really effective? Whereas the age generation is more like looking at the gay community as a whole. The other thing, last but not least, I wanted to point out the importance of migration, because a lot of people from the post-AIDS generation actually migrated from other countries. Their understanding, their attitudes, their beliefs in HIV and treatment and all the other things actually is linked to the history of HIV in their home country, and also the health policy and also the racial politics. When we say that we believe that like Asian gay men, they are risky for HIV, but at the same time, many of them they don't think themselves risky. They think white Australian men are more risky because they think that we are Asian men, we are conservative. Yeah, the white men, they are very sexually active. Yeah.
Okay, and
so it's interesting. Yeah.
I mean, with all that in mind, before we pass it back to Nick, do you have something that you'd like to see change in terms of engagement with Chinese background gay men that you'd like to see changed in the next 10 years when it comes to prevention, care,
Definitely.
treatment, all that sort of stuff?
So on tech contest, I think one very important thing is recognize that people life, a lot of migrants and Chinese gay men here or other Asian gay men here, their life is beyond Australia. So we have to think about probably develop collaboration and partnership with people, with other organizations outside New South Wales, interstate or even internationally with the Asian countries where the Asian gay men come from. I think this is one good place to start. Yeah.
Fantastic. Thank you so much, Horace. And we're going to go full circle back to Nick now. Nick, I think it would be great to talk to you about leadership, because when it comes to organisations like ACON, Positive People, with ACON especially, there were really bold targets that you set out to meet, say in 2012. So how do you feel about the progress that's been made in that period?
So just to comment on leadership, and I really think, what can be characterised with New South Wales HIV response for the last 35 years, really, or even 35 years, has been the leadership from many. Positive Life, BGF. Certainly, we've been very, very fortunate in New South Wales where we've had great political leadership pretty much for the life of the HIV response. And what that in turn has delivered is a really robust commitment from the government to, addressing HIV over and above what the Commonwealth might be doing at any point in time. And we see that play out in the bureaucracy with dedicated staff and resources to do this. When we knew we needed better data collection and surveillance, the health department didn't balk at injecting resources into really effectively creating the best surveillance system that we have probably in the world. But certainly community plays a critical role in that voice, in talking to government and making sure that, we keep HIV front and centre on the table. And I think there's always so many issues for us at a community level to be advocating to government on. And increasingly, we need to have a diversified advocacy agenda as community organisations. I think for an organisation like ACON not to, we would probably lose relevance with community because, with effective treatments, HIV isn't often central in our communities' lives anymore. And that's a great thing, but it's also something that we cannot become complacent about.
Well, I was going to ask you about that, because gains and progress has been made in the last decade. And then looking forward to the next decade ahead, we know that one of the enemies of progress is complacency. So what can be done to tackle that?
And I don't think our community has become complacent. Certainly around HIV responses. You only need to look at the results and the data that we're seeing and the uptake that we saw for gay men, particularly with the scale up for PrEP, that our community absolutely is at a point where I think we want to put new HIV transmissions behind us. There's enough work to be doing, focusing on putting in place great support services for the HIV positive community, particularly in relation to ageing. Then we really need to move beyond or envision a kind of time where HIV will have had its place. We've got marriage equality. We absolutely need to be focusing on trans and gender diverse health issues. But there's still a job to do. And the next 10 to 15 years, as sort of Ben's articulated and others here, we've made great gains in New South Wales. We had ambitious targets, and some of those targets are being met, but we need to keep up the momentum, and we need to be agile, we need to be responsive, we need to work with our partners to look at models of care or systems that we can, quickly bring in new technologies as they emerge. And I also think we need to really keep our eye on the data, because I think when we set the goals of the 2012 HIV strategy, I don't think we understood the nuance that we would learn about if we fast forward to 2019. I don't think we could have projected that we'd get much greater visibility within the data of what the needs were for overseas born gay men and what some of the challenges might be, including some of the challenges that I think at some point we've got to be prepared to say, we can only affect those changes to a certain degree because a lot of them are coming to Australia, often imported, if you like, because a lot of these guys are coming from countries where it's illegal to be gay. The stigma and discrimination is really problematic. And so they come to Australia, and thank goodness, testing is free, accessible, private, and that's great. So the impacts that we can make in some of the data may be kind of minimal. So absolutely the progress has been fantastic, but we've got so much more learnings now than we did in 2012, including, I think, for Australian-born gay men, where we're not making an impact, where we're still getting that 9% who aren't testing, where I think we've got to give much greater attention to drug use for Australian-born gay men and what that's looking like for positive guys and for negative guys in relation to treatment adherence or adherence to prevention. So, but we're getting more nuanced, I think, and we need to, as community organisations, POSLIFE, BGF, ACON, NUA, SWAP, continue having those conversations with our community and spotlighting those conversations and targeting them where they're appropriate.
Okay, thank you so much for that, Nick. Now, you have all been listening for such a long time now, and I'm sure at least several of you have burning questions out there. We don't have roving mics, but we've got time for maybe 2 or 3 questions. So if you put up your hand high, use your diaphragm. I'll repeat it out through the mic, and we'll get a conversation going. Any questions for the panel at all? That has been so comprehensive that they have been stunned and impressed by... Yes, there's one question right in the middle.
I've got a loud voice. So I think looking forward towards 2030, we're talking about looking at some of the smaller populations, so people who use drugs, sex workers and things like that. The data was 0.9% that are stubborn, and I would challenge that and say that they're fears within those communities. Is the way to engage with those people to look at the social determinants of their life rather than taking a medical approach to HIV?
I think we have to look at settings-based approaches, and can I just take a step back and sort of divert a bit? I mean, the stubborn heterosexual rate of HIV requires a very different response, and to some extent that I think the only solution to that is having high rates of testing in our general practice, and almost see increasing STI testing and HIV as part of being well and normal. And I think that there's still a lot more to be done about reframing what we need to do for good health anyway, and having that primary healthcare system that really supports people who engage with it, to have that sort of full range of testing and to normalise sexual health as part of that. I think there is much to be done, that we need to provide more holistic care where people access our health services, be it in drug and alcohol or sexual health and mental health. I think we have to put people at the centre of it, but I think health is part of it in terms of providing a more holistic, connected, integrated care space for those people that engage with us. But I agree that the social determinants of health, we need to recognise those, but I also don't want them to be overwhelming, because we're still, New South Wales Health every day touches the lives of many vulnerable people, and it's the question of, can we take that opportunity where they've touched our lives to provide even an enhanced service and a broader range of services?
So I think these interventions have to be both acceptable and accessible, and I think understanding some of the issues you're raising will educate us about how to make these things both more accessible and acceptable.
Look, I think that the challenge across the clinical sector and across the other support programs will be to acknowledge the fact that we have quite a spectrum of lived experience within New South Wales. There are some people who are doing very, very well. There are others who aren't necessarily doing so well, and some of the factors that underlie their not doing so well can be analysed and looked at in terms of the social determinants of health. People who, there's a quite high percentage of people who live on incomes under $30,000. They live alone. They have a range of multimorbidity. Some of these factors, I think, are going to actually impact on the way we have to deliver clinical and other services so that these people can actually get really good outcomes. And we mentioned just before the inequity, I suppose, in terms of metropolitan PLHIV and people who live in regional areas where they have a fly-in VMO 2 days a week in some areas, there's no S100 prescribers. So some of these issues, I think we're going to have to try and come to terms with in the next 10 years.
But just on that point, I think we can actually do innovative models of care. I mean, we know that we can do telemedicine pretty well. We can actually Skype people and do consultations over the phone. So I think it's about also making sure we recognise, there's good evidence for mental health interventions being delivered over the internet or through telemedicine. So it's really about applying general health system reforms and looking at what's fit for purpose in our response to HIV, because we aren't going to be necessarily able to engage with an S100 to maintain skills. And we also want to make sure that, people in rural regional have access to the best and latest advice and up-to-date. I think we also need to listen to our colleagues in general practice about how to support them. I think the HIV support program's been a really good case in point, where we basically have someone ring the GP who may have never diagnosed a HIV case, hopefully before they've even recalled the patient in, so that they can actually be really supported. So that first experience of that patient is an incredibly positive one. The GP, he feels supported. So hopefully the next time a patient comes in that they think, they should offer HIV testing to or have a discussion with, that promotes them to do it. Because we also understand that clinicians in our system have also acquired some interesting reactions to HIV themselves, which can actually perpetuate the inequity. So if they're fearful of doing testing because they don't want to actually deal with, disclosing the diagnosis, if they don't want to assist the patient in navigating the system or the contact tracing or referral to specialists, that can actually put barriers. So we also have to work with the professionals to make sure that some of the legacy issues that I think about making the special consent provisions, the additional confidentiality position, I can really understand of why they were needed at that time and why community fought so hard. But in my life, I've got to be telling doctors, you've got to do what's clinically relevant. If a patient comes in and you think they could have HIV, it is actually your duty of care to do the test and deal with the consequences. So I think there's still a little bit of work for us in the clinical system to make sure we're taking all those opportunities to diagnose people.
Yes, speaking of that, I think it's very important to educate the clinician as well. Speaking of a clinician, I'm also a nurse working at the HIV sector. I feel like the clinicians in the HIV sector and sexual health sector is very good. They are doing very good at their job. But however, at the same time, like PrEP is rolling out to all GPs. Not all GPs, they are very well prepared to do all this. I think this is very important to educate the clinicians how to provide the service to different spectrum of the different group of people. Yes.
That's actually a really good wide-ranging question to leave it on, because I do believe we've gone a little bit over time. The conversation, at least for this event, ends here, but it continues out in your communities and in your workplaces as well. So please engage with the report, share the findings with the people who need to hear it. But in the meantime, could you please join me in thanking our wonderful guests, Nick, Kerry, Tony, Horace and Lance. Thank you so much.